Clinical manifestations of common skin disorders. This is just kind of not exactly a comprehensive list of skin disorders. These are the more common ones, like acne, atopic dermatitis, cellulitis, contact dermatitis, folliculitis, fungal infections, carbuncles, herpes, impetigo. I'll let you read the rest. Assessment data for the skin. Be sure to get a very detailed health history, such as medications, previous skin disorders, any recent exposures to hazardous material, changes in skin condition, maybe sunburns, history of sunburns, excessive bruising, wounds that are slow to heal. For assessment data, you, in addition to the health history, you'll inspect and you'll palpate. So you'll inspect the color and the condition of the skin, and then anything that's impaired, you want to compare it to healthy skin. And so compare it to the opposite side or any adjacent area, really. If there's a lesion, note, location, size, shape, color, pattern, characteristics. Measure it. The measurement will go in charting. Teach your patient on the A, B, C, D, E, asymmetry, border, color, diameter, elevation or evolution of a lesion. For palpation, feel the surface for characteristics, the temperature, pinch the skin for skin turgor, and again, compare it to the opposite side. Assessment data in wounds and ulcers. Again, location, size, color, cleanliness. Is there an odor? Does it drain? What color is the drainage? And then right here is the charting on the color. Staging the ulcers. I imagine you will have a few questions over staging pressure ulcers. So stage 1 I have outlined right here, stage 2 here, and then stage 3 a little, and stage 4 down a ways. So stage 1 is non-blanchable. Skin's intact, it's dark a little bit, could be painful, could be firm, could be soft. Stage 1s are really hard to detect. Stage 2 would be your partial thickness ulcer. Loss of dermis, presents as shallow open ulcer with kind of a reddish, pinkish wound bed. It might be open or intact. It could be shiny or dry. This should not be charted to be used as skin tears, tape burns, incontinence, maceration, that kind of thing. Pressure ulcers are entirely different than those things. Stage 3 would be a full thickness ulcer. Subcutaneous fat would be visible, but anything else isn't. So the bone and the tendon, the muscle are not exposed yet. Stage 4 is the worst. That's when the bone, the tendon, the fascia, or the muscle is it's exposed. You might see eschar. These are the wounds that you measure depth, and these are the wounds that predispose the patient to osteomyelitis. And then, of course, there's the unstageable or the unclassified, where the depth is unknown. Could be eschar in the heels. Okay. Common diagnostic testing, Wood's lamp testing, maybe a tissue biopsy, wound culture, patch testing, serum protein level. Nursing interventions. Keep skin clean and dry for your patients that have impaired skin integrity, like your elders. Keep the skin clean and dry. Use protectants. Make sure the patient's adequately hydrated and their nutrition status is good. Avoid excessive sun exposure. Be sure to be safe. Don't burn yourself. Vaccinate against HPV. For secondary prevention, screening would be the ABCDs that I talked about earlier in skin cancer. So asymmetry, border, color, diameter, elevation or evolving. So you want to check to see if a lesion has evolved over time. For tertiary prevention, it's nutritional support, pharmacotherapy, surgical interventions, and wound care. Dressings. The goal is to maintain a moist environment. So I had a student ask a question about, a moist dressing and moist versus wet. So the rule of thumb, if you wring it out and fluid comes out, it's wet.